Okay, so now we are recording. It's our first lecture. This is your first lecture of your last semester in the program. So, so congratulations to everybody for making it here. That's pretty fabulous. And this is the last time you'll have a first lecture in this MSN program. Okay, so this is something new. I'm curious to see how this works. We're going to do a poll. Let's see if anybody... I'm going to do a poll and launch a question. Can y'all see a question somewhere? Can you click on something? This is new. This is something that we're going to give a shot to based on feedback, really helpful feedback that some folks mentioned on the idea surveys, that would it be possible to have it be a little more interactive and maybe kind of test our knowledge as we go. And I thought that's such a great idea. So whoever thought of that, thank you. So I think the question that I can't really see, but if y'all want to go ahead and click what you think, kind of test your knowledge. So a behavioral therapy approach should result in what? Excuse me. And we will close. So appreciate y'all responding. So the question is just kind of right out the bat. A behavioral therapy approach. And it's okay if you don't know this. All right. So let's go ahead and lock this down. Oh, a few people haven't voted. Did everybody vote who wants to? This is not for a grade. This is not. This isn't compulsory. So let's just lock it down. So behavioral therapy looks like a slight edge to insight, maybe some emotional expression, maybe some self-actualization. And the moral of the story is that from a strictly behaviorism, we'll go to the next slide. The three waves. The purpose of behaviorism is strictly to result in behavior change, which might seem like, oh, well, don't people have to get insight into why they're doing it, or don't people feel better after they make behavioral changes? Sure, they might. But we're talking about these three waves of psychology, and these three waves of which are essentially each different perspectives of how to approach a patient situation. What are you aiming for? How are you going to conceptualize the patient's issue or goals or challenges, and kind of basically what are the fundamental techniques that you're going to use to get them there. And it started with Freud, going way back, kind of the guy who said, I think behavior might be motivated by things you can't see. And I think people's behavior might be motivated by things that they don't necessarily understand. And that was also when we started thinking, well, maybe mental illness or emotional problems, psychiatric problems, maybe it's not demonic possession, and maybe it's not a moral failure, even though that certainly lingers with the stigma with that. But the whole point of psychoanalytic approach is that people need insight. They need to understand why they're doing what they're doing, what relationship was unsatisfactory with their mom when they were little. It's always about mom, and it's always about hidden, internalized, such and such and such. You can imagine that's hard to measure. So these days it might be more difficult to get reimbursed for it. It doesn't maybe progress on a schedule. But when you see Sigmund, and I think his full pronunciation of his first name is Sigismund Freud, and then you had Carl Jung. Those were the big psychoanalytic guys. So everything was about meaning and symbolism and invisible internal things. And then B.F. Skinner said that's garbage. Let's focus, science in the 50s. Oh man, post World War II, all of this economic and scientific progress. Let's just focus on science and what you can see and what you can change. And that's when that introduces the concepts of classical conditioning and Pavlov's dog and operant conditioning every time we talk about consequences and behavior modification. That's all behaviorism. They don't care why you're doing what you're doing. They want to move people toward just a different something, very different from psychoanalytic. Kind of cold, kind of impersonal, isn't insight or emotion kind of relevant? So the reaction to that was humanism. Carl Rogers, I guess more so in the 60s and 70s, came up with a totally different idea. That maybe for people to change, they don't need to do regression therapy to when they were 6 months old. And maybe all that people need to change is a certain relationship with a provider to kind of guide them through that. People are inherently good and they'll get where they need to go on their own. We as providers are not experts and we're not mysterious controlling people. We're supportive and we're going to reflect to them their experience. And you can certainly see how these are not approaches that solely in and of themselves are going to be appropriate with every patient with a severe mental illness, say. Humanism is not the only approach to appropriately care for someone with schizophrenia or someone with severe depression. But you can still choose to take either of these, or any of these approaches, or an eclectic approach if you like parts of some of these concepts and they're really authentic to you, and that's a very important part. So, okay, let me see. I'm trying to do this right. So these therapeutic modalities, these are approaches, these are concepts of people in the world and how to approach therapeutic interactions, treatment interactions, a provider relationship. And each one contains kind of buffet table techniques that you may choose to master and implement in certain patient situations. It doesn't mean you have to be a cognitive behavioral practitioner. You can use cognitive behavioral approaches when appropriate. And we would like you to be familiar with Gestalt and existential and interpersonal. There's some readings in Wheeler about that. You are more likely, though, to be tested on the concepts of these orange ones. Okay. Poll number 2, I think. Let's do this one. Let's see if y'all can see another little poll. What y'all think? I wish I could see what it looks like for y'all, because it looks different for me. And again, this is not for a grade. This is just to kind of gauge where your thoughts are. Looking good, looking good. All right. Oh, we've got a tie. Does anybody want to vote to break the tie? All right. Lock and load. Oh, thank you, Dr. Fogger. That's cool. That's a big old screen. Okay. Thank you for sending me that. All right. Da-da. So excellent to the 50%. Thank you for all voting. That's pretty cool. That is exactly right. Cognitive Behavioral, we'll talk about that one first. Designed by Aaron Beck and continued by his daughter, who's still rewriting his books. The purpose, kind of the fundamental idea behind cognitive behavioral therapy that Wheeler will go into a good bit more detail, is it's this idea that based on our experiences, we develop concepts of the world and ourselves in the world and what ought to happen and who we are and how people should treat us and how we should act and what's good and what's bad. We sort of write these programs in our heads to explain situations that we've been through. And sometimes those core beliefs, faulty core beliefs, that you've learned based on difficult experiences, traumatic experiences, just life experiences, someone, maybe you were in relationships with people who kind of taught you the wrong thing, or their view of the world got imposed on you that women should never be assertive or men should never show feelings. I mean, whatever it is. Those are core beliefs that a lot of people have that can cause problems in day to day. So cognitive behavioral theory, you see behavior right there, so you know a big part's going to be changing things. Where they differ from strict behaviorists is the understanding that thinking and our interpretation of events largely influences how we feel and what we do. That it's not just with behaviorism, I pay for things that I want as opposed to stealing candy from the checkout. I pay for things because if I don't, I'll get in trouble. So it's the consequence that makes me pay because I don't want to get, arrested or kicked out or something. That's a behavioral approach. Cognitive approach is that, I pay for things because that's the responsible thing to do. And I would feel guilty if I didn't. So cognitive behavioral theories approach practitioners are going to remember that however you interpret situations, and that's going to be based on some old experience, some old conceptualization that you have, if you can get to the heart of what those are, that may be all the problem. I'm a bad person. I'm unlovable. If I'm alone, I'm going to die. I can't, it's rude to ask for help. It's rude to speak up. Bad, only good boys do what we don't think, we're not aware of these core beliefs. It's like the iceberg, and it's the only thing that we're ever aware of is the little part that sticks out above the water. But there are these core beliefs based on experiences and repetition and what you're taught. So how we structure our experience determines how we feel about it, determines our thoughts. Schemata is just a fancy way of describing the blueprint that you use to make sense of situations and people in your life. And it might be based on maladaptive beliefs, like real common ones that you hear people will come out when you're working with them is nobody likes me. Nobody's ever going to accept me. I don't deserve to be happy. I mean, and if you say them out loud, you think, what are you talking about? But underneath people's interpretations of things, everything's going to get colored by however you think the world makes sense. And those filters of our world are developed really young. So Freud was actually onto something in that way. That experiences really young determine kind of how we see the rest of everything. So the goal of cognitive theory is not just to change behavior by focusing on the behavior. It's let's look at what underlying beliefs this person uses to make sense of the world. Are they accurate and are they helpful? Are they adaptive? Or do they result in a lot of negative emotion, a lot of negative, unhealthy behaviors? So when you're working with anxious people, folks with depression, folks with relationship problems, to an extent, people with emotion regulation issues, if you have a core belief of, I should never be inconvenienced, and something's wrong if I'm in traffic, and I mean, if you really think that that's how the world should be, well, you're going to be angry and mad a lot of the time. One of the things that can be helpful if you're working with people, especially folks with anxiety, like general anxiety, anxiety around relationships, depression to an extent, you can just print off a list of cognitive distortions, because people tend to fall into patterns of how our minds get us into trouble. You know, we only have so many parts in our brain. We only have, so there's a limited number of ways and therefore patterns people fall into how they kind of misinterpret the world. Real common ones: all or nothing thinking, should statements. You can hear patients when they say everything that they talk about. There's a lot of shoulds, there's a lot of nevers, a lot of always. People are entirely good. People can't be trusted. For the most part, when folks are talking in extremes, they're to a certain extent emotionally dysregulated at that moment. And by emotionally dysregulated, I mean the percent of their cognition that is prefrontal has been reduced, and instead that I don't know, it's like when you control alt delete and you pull up the little thing that lists all of the programs that are running. When people are talking about they never do this or he always does that, that tells you that their task manager, okay, we have some emotional, sympathetic, reptilian programs are running, because nothing is absolute. Nothing is all or nothing. So when people are talking that way, that can be a helpful cue for them, is when you notice yourself saying always and nevers, that should be a cue. Oh wait, I might be emotional. I might not be in my best self. Let me try to re-regulate so I can actually reason based on fact and history, and not just based on how I'm feeling at this present moment in time. And you can just hand this to patients and say, does any of these sound like you? And they'll say, oh my God, yes. All right. This is real. Another little poll. This isn't earth-shattering, but any guesses about which? And, they can be more than one. All right. So labeling is in the lead at the moment. Excellent. Bless you. Anybody else interested in voting? We can shut it down. So yeah, so this, and again, it's definitely not mind reading. It's definitely not should statements. This is a little more of an example of labeling than all or nothing thinking. Maybe an all or nothing thinking might be, I overslept my alarm. I never do anything right. I always screw things up. Would be that. Labeling is instead of, what happened is that a mistake was made, but instead of saying that, someone in a very emotional state who might be more likely to make events and things a reflection of themselves, which you have with some, with borderline personality disorder in particular, you make it about you as opposed to about what happened. And it can just be helpful for people to realize folks don't realize they're using these either until we bring it to their attention. This is just how people think and how they do. So imagine the benefit to people to say, do you realize that you're not the only person who thinks this way? And this tends to reveal thinking that's not entirely based in fact. You don't want to tell people they're stupid, of course, or that they're doing anything totally off the map. It's just their thinking is not entirely based in fact. So with cognitive behavioral techniques, and you don't have to be a cognitive behavioral provider, but you can still apply techniques of it. And these are some. Automatic thought record is a real basic one. If you work somewhere that you have, if you work somewhere that you have 30-minute sessions for follow-ups with patients, which is luxurious, you can do this kind of thing. Automatic thought record is a way to try to examine the piece of the iceberg that is visible above the surface of the water and use that to give you access to the core beliefs that may be problematic. And the automatic thought record is the way to do that. It's real simple. It's just a journal, essentially. It's very clean. It's very orderly. And allows people to, based on the automatic thoughts, try to figure out. This isn't super clear right here, so my apologies. This is available in all sorts of forms online. They're all perfectly fine. One page piece of paper, and all you ask the patient to do is, date, the time, and then what's the situation? Well, I was, here's an example. I was working with a college-age person, went to a party, went with a friend. The friend kind of ditched me once I got there to go hang out with other people. So suddenly I'm alone at this party. That's the situation. Then you ask them to jot down, so this would be done, I would say, over the next 2 weeks till I see you again. Anytime you have an experience where you feel strongly sad, you feel strongly anxious, you feel strongly happy, really excited, any kind of standout emotion, once you get back, in a place where you have a couple minutes, just jot down the situation, because it's also helpful to encourage people, times when you felt proud, times when you felt satisfied, excited, to not just focus on what's so negative, but to get an idea of what thoughts and what core beliefs lead to positive, healthy, adaptive emotions and behaviors too. That's another application of this. So they write down the situation. I'm at a party. Friend ditched me. I'm by myself. Automatic thought. What goes through your head? And this is when you want people to jot down the unfiltered, no holds barred, not interpretation, just really what chatter went through your head as soon as the friend walks away and you realize, oh my God, I'm alone at this party. Because those are the automatic thoughts. They're not deliberate. They're reflexive. But they are generated by whatever the core belief is as applied to that situation. So an automatic thought might be, oh God, I'm by myself. I bet they are looking at me. I bet they think I'm pretty lame. I'm freaking out. I want to leave. I don't want to be here. This is so stupid. These people don't want me here. Da 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 da. No interpretation. And then, did you really believe it? And at the time, the person probably really did. And then what feelings were associated with those thoughts? Because you think of emotions and feelings, emotions and behaviors and thoughts as package deals. They all come together. You don't just feel something that there isn't a thought associated with it. You don't do something that has absolutely no emotion or thought behind it. So, what emotion? I felt lonely, I felt nervous, I felt awkward, I felt stupid, I felt such and such. So just in that, you can, and then when you look through, kind of filter through the automatic thoughts, you would see a core belief of, like we talked about earlier, feeling unlikable, feeling unwanted, this core belief that things aren't going to go well in social situations for me. And so that's what you look at, that I can't make friends. I'm socially just awful. People can come to develop those beliefs over time. And unless you challenge them, they stick around. That's the problem. So the whole point of this automatic thought record is to help people become more aware of their automatic thinking, to get to core beliefs. And then you ask yourself, because on that previous slide I talked about consider the evidence, evaluate the evidence, is that then you kind of walk the person through, well, let's look at that. Let's look at this core belief that you're never going to have any friends and people are never going to like you. And then you have them go back through, well, and think of exceptions. Who do you have in your life that you enjoy hanging out with? Let's think about times when you went out and met people and it was great and it was fine and you enjoyed it. So you apply reason and cognition to challenge this core belief that's just sort of automatic because it's just there. It used to be true and it used to be accurate, but it may not be accurate or helpful anymore. And then the person can say, well, there is conflicting evidence and maybe that core belief isn't true. So, okay, well, what's another way to approach it? And then they will practice and walk through a more adaptive response. I'm nervous right now, but let's see, what can I do? I'll just go over there. I know that person. I have class with that person, so I'm just going to go kind of talk with them. You rehearse and you practice. This is when it gets behavioral. You rehearse and you practice alternative responses. And then the next thing you know, people have more positive experiences. Okay, let's do one more on this topic. And then we'll move on a little. So which of these is true? Uh-oh. And a hint is they might all be true. If you're having trouble picking which one is the most correct, it's because they're all right. And that's really the whole point behind. Yeah, so somebody picked the first one, and because it's there we go, awesome. So everybody, that's so cool. So yeah, our interpretation of events. If you're sitting in traffic and somebody cuts you off, if your interpretation is that punk, I cannot believe you don't get to do that to me. That is, well, the next thing you know, your behavioral response is going to be a lot of yelling and your feelings are going to be anger, as opposed to if you interpret it as, everybody's stuck in this traffic. They're different from anybody else. You're probably not going to yell and scream and you're not going to be really angry. So That just shows how your interpretation is really going to determine how you feel and what you do. And that's the good news, is that if you change how you think, then you will change how you feel. Now, that doesn't mean that CBT is going to get people out of a severe depression or get people out of a manic episode or make panic attacks never happen. No, absolutely not. This is a complement when you're working with someone with a condition that requires medication. But for someone who has milder anxiety, milder depression, social, they're real nervous, meeting people, they could use some social skills, some anger management skills, that medicine's not needed. This is really appropriate for them. These are just some techniques. You can Google any of these things and get YouTube videos and handouts and printouts and websites. And you can teach folks in 10 minutes or less thought stopping. Like when you hear yourself saying never and always and forever, and then say, oh, I'm doing that thing. Stop. Distract yourself. Do something else. Progressive muscle relaxation, all these things. That's what's so cool about this, about CBT, is you can just give people little nuggets that'll be really helpful and complement the rest of the treatment they're in. All these applications. You may have a kind of a question on ANCC or on the comp exam about it, that requires you to be familiar with applications of CBT. You'll experience this a good bit wherever you end up practicing. Moving on to another approach. Since traffic issues engender so much anger, we often tell folks, could be that person. Absolutely. Yeah, Kelly. You're saying that traffic gets people real worked up. Could be that the person has a sick child or they just lost their job. Absolutely. Yeah. However you choose to interpret it, that is going to influence huge your degree of distress. So that's a good point. So Rogerian therapy, person-centered therapy, if any of y'all want to train to be therapists and you choose to practice this, great. The provider is not the expert. The provider is an equal playing field. It's a client, not a patient. They're equals. And it can be helpful for people with anxiety, people with depression. This is completely non-directive. So as far as giving lots of information, suggesting lots of suggesting techniques to practice and things like that, this isn't what you're going to do. Really time consuming. And there's not really an endpoint in sight, and the goals aren't real well defined. So, but the reason why we want to bring this up is because of how important what Rogers introduced is that to help people change, he believed the only three things that you needed were essentially authenticity as a provider, unconditional positive regard for the patient, and that you're really trying to understand their experience, understand where they're coming from. His belief was that was the only thing you need. Yeah, and I don't have to agree with that, and neither do y'all. But it's a really good approach to take. So last but not least, y'all have been such good sports with this new poll thing. Last but not least, which of these things is crucial, fundamental to Rogerian? Provider congruence. And we hope that's kind of a sort of a interesting concept, I guess. But what we mean by that is that you as a provider are authentically yourself. And the right answer is provider congruence. Provider empathy, sure. Sympathy, that tricky difference. That empathy is about trying to understand where they're coming from, how they feel, not how you feel about it, which is more of a sympathy thing. So whatever approach is authentic to y'all, we got 60 people, we got 60 different authentic selves. So whatever techniques are natural to you or believable to you that you really believe in, adopt those, because patients they can tell if you mean what you're talking about. So recommend things that you believe in, that you support, that you think are helpful, that you've maybe even tried yourself. So person-centered therapy is an approach. It has some concepts that are universally applicable. You're not going to fail the ANCC exam if you're not an expert in person-centered therapy. So it is something, though, that we want you to be familiar with, because it's a huge pillar in psychology and psychiatric care. Solution-focused therapy, also very behavioral, kind of like CBT. It's outcome-focused. It's future-focused. It's a no time like the present. And this approach, kind of the things that they believe, is don't focus on the past. Don't focus on the pathology, which is often, when y'all do intakes, this is a question I don't think I can do a poll, but when you do intakes or sessions with people, do you tend to focus more on symptoms and things that are still wrong? I know I do. That's a good bit of the sessions when people come in for med checks and for intakes. Just some things to think about, because you can do an intake where you're really trying to drive home a diagnostic assessment and you're asking about all these symptoms that are there. Has your energy been bad? Has your anxiety been bad? Describe your panic attacks to me. Describe your nightmares to me. And that's all problem focused. Solution focused, they realized that another way to move people toward change, and again, you're not going to solution focus therapy somebody out of psychosis or out of mania, but this can be very helpful as an adjunct to those things for people who are capable of engaging in a cognitive based therapy interaction. So anxiety, depression, concerns about relationships, concerns about money. You can apply this. Substance use. But there's no absolutes. It's very team-oriented. They don't think that manualized treatments are the cat's meow. They have their place, because they really want the solutions to be very fluid, and you're always changing, and you're discovering patient motivation along the way. You're discovering new benefits. But mainly solution focused is you think about what's going well and where you want to go, more positive things as opposed to less negative things, less depression, less anxiety, less anger, less substance, which is often how I know I approach sessions. Insurance companies want to see assessment of the system. You can write notes about this and focus on what the patient needs now in the session. Yeah, this may seem really natural to some people, some of y'all. You may like this a lot. This can be helpful. These techniques, not that you have to be a solution-focused provider, but these techniques can be helpful at certain times in certain situations. And these are just some examples. Wheeler talks about them to kind of set the stage of hope and change at a first session. Somebody schedules an appointment, you see them in a month. Well, since you scheduled this appointment, what are some things that you've done that have been helpful? Ask the patient, what's helped your anxiety? What's helped your mood? What's helped your energy? To address that they have solutions in them already. Things are better, so let's instill some hope. And they did it on their own. Instill some confidence too. It's a great question. Y'all know about the miracle question, of course. If you're wanting to focus on what would your life look like? How am I going to know? How are you going to know when you're better? How am I going to know? It also is going to reveal what is important to that person. And the exception question. Tell me a time when you didn't feel so anxious. Tell me about a time when maybe you didn't drink as much. Tell me about a time when your marriage was better, when your relationship with your kids was better. Because what you're getting at is what did their life look like when it was more satisfactory, or when their symptoms were less, when they were more productive, when they were more engaged in their community. Signs of the opposite of impairment and functioning, good functioning. What kinds of things were they doing? Because probably if they did those again, they would get similar results to the last time. Well, I was exercising. Well, I was going to church. Well, I was working. I was volunteering. I didn't feel so depressed, and I was able to get out of bed. So that becomes the things, well, let's work on those. Let's get there. Because what we do, like we talked about in CBT, this is solution focus is certainly close to CBT. It's very behavioral. But the idea that what you do influences how you feel. So these are just things to get an idea about what's important to the person. And again, from a severe, moderate, mild scale of symptomology, this is going to be helpful for people more on the mild to moderate. People who are cognitively intact. People who can hold a conversation with you. And this is kind of cool if y'all wanted to just practice this. And all of these techniques are things that you practice and you get better at them. And they feel awkward and you don't do them well at first, like everything else. A scaling question is really helpful, useful also in motivational interviewing context of getting people to talk about what's important to them and kind of argue for change. So an example would be asking a patient, how important is it for you to get your anxiety to a more manageable level? And they'll say, oh, it's like a 10 out of 10. So you'd say, okay, so that's about as important as it can be. Why is it a 10 and not a 4? And it's always why the number you said and why not a lower number. So why is it not less important to you? And they'll say things, they will start talking about what is essentially motivating them. And that is tremendously helpful because they're talking and hearing themselves talk about why change is good. And that's what the decision balance is all about in motivational interviewing, is getting a person to become more aware of why change is important. Well, it's because, this person might say, well, it's because I feel just in knots when I go here, or I'm not able to go to the store, or I'm not able to go to my kids' soccer game, or it's going to cost me my job. It's other people, family's concerned about me. Like, so now you know what's so important and what's motivating this person. That's awesome. And they're arguing, they're getting behind themselves, which is cool. And a coping question, just a simple technique to use to give a patient an opportunity to talk about things that they're already doing that are solutions, to get out of this idea that they come in and they know nothing and they haven't made any progress. Get them to kind of reframe things that they're already doing well to keep doing. Real behavioral. Identify what's helpful, do it more. These are things you can use in any session, and I encourage y'all to. Scaling questions in particular, helpful when a patient is in the contemplation stage of change for some sort of behavior, that you're trying to help tip them into the commitment preparation. Okay, let's do it. Is this something, can y'all describe maybe an example of when you've tried that with a patient, perhaps? I'd love to know. If y'all haven't, and this is the semester when hopefully you're getting more independent time with patients, but if you haven't, I encourage you to identify some sort of scenario with a patient to practice this scaling question. This can be about exercise. This can be about taking their blood pressure medicine, going to appointments. How important is it for you to, why is it a 9 and not a 4? Whatever they say. Or if they say a 6, why is it a 6 and not a 2? This little slide is just neat because it gives you some examples of what patient language that you're listening for when you're trying to determine where they are readiness-wise for change, using smoking as an example, any kind of substance. Use language that people will use, patients will use to indicate which stage they're in. This slide isn't on, let's show you. Is that it? Yeah, okay, good. This slide is new, so, but it's not, this wasn't in the readings. This is just something that I wanted to add. Another cognitive behavioral therapy application is dialectical behavior therapy. It's a particular interest of mine that I'd be more than happy to talk to anybody who's interested in learning more about it. Not real practical to our purposes to go into it in a lot of detail. But DBT is a cognitive therapy approach that has been applied to about a jillion things these days and has empirical evidence supporting it. Designed for borderline, but is really applicable to anybody. Skill enhancement to people who have trouble with emotion regulation and relationships. People who feel very overwhelmed very quickly by how they feel. And it's for we'll visit this website super quick to kind of show you some more resources if you essentially just want to become more familiar with some of the techniques that you can kind of take and apply separately for people. Mindfulness, which is deliberate non-judgmental attention. One of the reasons why folks with borderline PD struggle with this is brain structures which have been changed by trauma or by neglect as a younger person, with genetic kind of loading going into that, because it's always nature and nurture. But these folks have difficulty just in a resting state when there's not really anything being demanded of them. They have less connectivity with the parts of their brain that involve kind of sensory awareness or memory, kind of autobiographical memory. Your parietal lobe, that's where you have sensory input. So folks will kind of feel separate from themselves, and they're more likely, people with borderline personality are more likely to feel disconnected from the present, disconnected from their own feelings, disconnected from their own thoughts, kind of that running commentary we all have. So a skill that is helpful for people who deal with that is to practice deliberately paying attention to the present and to their thinking and to what they're hearing and seeing and smelling and watching and doing. It's going to be pretty difficult to ever feel like you're a consistent person when there is poor connection between kind of your day-to-day experience and who you know yourself to be and then what's actually going on around you. So by helping them strengthen those connections by practicing deliberate attention to what they're doing and describing it, that's the number one skill you work with for people with borderline PD. And the next one is distress tolerance. Anytime someone gets upset, anytime people are sympathetically activated, their body goes into a mode, well, let me return to homeostasis. And when people don't have a lot of useful inner speech, and when people can't recall things that have helped before that are maybe healthier, like, I could probably call somebody, or, last time this happened, last time I had a real anxious time, or last time I was this sad, it eventually went away. We're able to talk ourselves through that. Yeah, default mode network, DMN. Yes, ma'am. Default mode network are the brain structures involved with just kind of being you when there's really nothing else going on. Memories, values, where you've been, what you've done, who you know yourself to be. So with distress tolerance, when people become scared, really angry, or really hurt, and that task manager's kind of getting cluttered up with different things, trying to run the show, folks will do something to make themselves feel better. And unfortunately, self-injury, substance use, spending lots of money, things that essentially tip the scales toward reducing distress, getting your good frontal cortex back online and able to run the show. Self-injury, unfortunately, does that. Substances can do that. Or at least substances can make you less aware of the distress. That's really what they do. Or actually, I guess, physically oppose all of that noradrenergic activity that tends to be prominent when people are panicking, dysregulated. And folks with borderline in particular have those connections. Again, they are sort of always scanning for a threat, and their threat scanning device is too connected to the amygdala, which means how I interpret this situation to be. And I got kind of a hypersensitive Sensor there, and now big emotion. A little thing doesn't trigger a little bit of emotion. It activates a large behavioral response. And it's not as well connected. If you remember the orbital frontal cortex, when we talk about ADHD, that's impulse control, that is not registering on the task manager. So they're not able to temper impulsivity. Medial prefrontal cortex is involved in emotion processing, and it would be nice if they could kind of regulate emotion some, but it's not online. So you teach distress tolerant skills like relaxation, like distraction, self-soothing, to have an alternative means to bring the person back to homeostasis that isn't destructive. Because unfortunately, destructive things work in the short term. Emotion regulation, take care of yourself, establish healthy patterns, rest, eat, do things that are enjoyable. Start building a history of self-care, essentially. And then interpersonal effectiveness, folks with borderline PD in particular, or any kind of relationship in effectiveness history. This could be helpful for the same reasons that we talked about. If you're hypersensitive to big emotional responses and you're looking for any sign of conflict, of rejection, then you're going to be likely to have a relationship history that's chaotic at best. Ta-da! dbtselfhelp.com is essentially some folks who put the skills manual online. So you can go in those 4 kind of skills modules that we talked about: mindfulness, distress tolerance, emotion regulation, interpersonal. They're all there. You can click on any one of them. You can print these things, or you could buy the manual yourself. I'm going to go down here to Dear Man. So it just lists skills and examples so that you can become more familiar with this and you don't have to buy the manual necessarily. Distress tolerant skills, tons of examples. So that's available to you on that website anytime. And again, I'm really happy to discuss it with you too, because DBT has been applied with a variety of populations with benefit for teens, folks with anxiety, depression. They're using it as an adjunct for folks with bipolar disorder, anger management, just general emotion dysregulation. And I really recommend, if you want to spend $40 on a couple of books that are going to have techniques and printouts for you to hand patients with depression who deal with anxiety, that those two are really good. It's helpful to have tools to give patients for them to practice and use. People tend to stick with providers when they find them helpful sooner. So augmenting medication with talk therapy with practice at home is, you're setting the patients up with the most resources available to them. So kind of the take-home message from these mainly cognitive behavioral, solution-focused. We want you to know the difference between what's the point of behaviorism, what's the point of CBT approach, what's the point of a solution-focused approach. Fundamental techniques to both of them, kind of those questions that we mentioned in solution focused, core beliefs, automatic thought records, indications for these, and kind of just, get one of the workbooks, look through them, go to Barnes & Noble, flip through it, and you don't have to pay for it. You can get a feel for it that way. But it's important for us to be able to give the patient something to practice, because we're giving them a chance to see that they can do things themselves to make changes and feel better, and not just have to rely on medication. And again, these are for more, cognitively intact, not severely symptomatic people, folks who can reality test, who can attend long enough, people who can understand your instructions, what they need to go home and practice, those kinds of things. So hopefully that's helpful as adjuncts to your practice. But that is the last slide for the evening. So any kind of last minute questions? Please be sure to submit your application for degree by Friday. Please. And there's a little post in the discussion board in this class explaining what you need to do now, but what can wait until later. It's really just that. It is just the application for degree. So if you can't find it, if you don't know who to send it to, let us know, because we want y'all to graduate. All right, I think next week I think we're talking about inpatient. Yeah, kind of acute issues, inpatient, those things. So, all right, everybody, do you know when our forms? Those are going to get submitted, I was told, end of this month, beginning of June. So yeah, so I'm glad you brought that up. Y'all should be able to still open up your accounts, but I think someone mentioned that they weren't able to register for the exam because that batch hasn't been batched out to them yet. So what you can do in the meantime is just go ahead and set up, okay, thanks Jennifer, is just set up an account. All right, everybody. Well, thank y'all for participating in the poll. Feel free to send me an email if you find that addition helpful, and we'll keep doing it. And y'all have a good evening, okay? Email us with questions.
Night, everybody.
Good night, everybody.